Thank you for participating in the Safety Program for Perinatal Care II program, also known as SPPC-II, presented by the Agency for Healthcare Research and Quality, AHRQ, and the Alliance for Innovation on Maternal Health, AIM. This module will introduce you to the SPPC-II program and the Teamwork Toolkit for Severe Hypertension bundle. It will serve as the foundation to the remaining training modules that will cover a suite of useful teamwork tools and their application to managing severe hypertension in accordance with the AIM framework. Guided by the vision to achieve safe health care for every woman, the Alliance for Innovation on Maternal Health, or AIM program, is working towards the elimination of all preventable maternal mortality and severe morbidity across the United States. The mission of AIM is to continually improve patient safety in women's healthcare through multidisciplinary collaboration that drives culture change. To this end, AIM has created multiple patient safety bundles designed to address specific concerns within obstetric care, working towards the improvement of overall maternal health outcomes. AIM partners with state teams and health systems to align national, state, and hospital-level quality improvement efforts and implementation of the patient safety bundles. We know you're working hard to align yourself with the AIM mission and vision statements by committing all you can to your clinical practice. You may be surprised to learn that patient safety isn't simply about the application of clinical knowledge and expertise. While these technical elements are essential, there's a second side to care that complements clinical skills, termed adaptive because they enable translation of technical competence into practice. These components include the cultural and socio-emotional elements that deeply affect the way technical elements of care are delivered. Consider for a moment how your ability to do your job is enhanced or hindered by your working relationships. Imagine how the care you provide might be or feel different when you're completely in sync with your teammates versus what it might look like if you had completely dysfunctional team dynamics. Totally different, right? Hopefully what you take away from the Simple Mind exercise is the understanding that when we have the goal to provide safe care to every woman, we have to consider both whether we are caring for her with the best clinical knowledge available and within the most effective adaptive setting. The AIM patient safety bundles that your organization is implementing satisfy the technical side. This Teamwork Toolkit aligns with those bundles to help improve the adaptive side of patient care. The SPPC-II Toolkit will do so by providing you with specific tools and strategies you can use when working with your colleagues to provide team-based care to your patients. This toolkit has been designed to connect established teamwork concepts within the context of AIM's Patient Safety Bundle for Severe Hypertension in Pregnancy using AIM's 4Rs framework. It is comprehensive in its ability to teach language, skills, and tools you can utilize with your team daily and presents a case scenario that demonstrates how these strategies may be used during a case of severe hypertension. Not only does the toolkit provide instruction on the adaptive skills that allow you to best engage in teamwork that keeps your patient safety and quality of care at the forefront of everything, but it also discusses how to have difficult conversations and interactions with coworkers and colleagues that come from working in a stressful and busy environment. The terms and concepts on this slide will be defined and explored in detail as you complete their respective modules of the toolkit. This toolkit was built with the understanding that you are a busy working provider who can only afford minimal participatory time on online modules and in in-person discussions. Therefore, each e-module will explain 1 to 2 useful teamwork tools and is expected to take no more than 12 minutes. The commitment to in-person team debriefings is minimal. This introduction e-module is the longest of the 8 online e-modules and will be completed first, as each of the remaining modules will reference the scenario presented to you within this introduction. After completion, you can either follow the suggested order, or you can complete them in random order, depending on what best fits your learning needs and the direction given by your hospital AIM team lead. They can be completed in one sitting or over several weeks or months. They can also be reviewed as many times as needed. After completing the modules, you're expected to participate in at least one facilitator-led in-person debrief session. These sessions will help apply the skills and tools you learn in the e-modules to real-life scenarios. The intention is to strengthen understanding of applicability and to provide a guided forum that builds team interaction and allows for role-play practice of the tools. Check with your hospital team lead for more information about the schedule of these sessions. Your organization's champions are tasked with ensuring that everyone receives and uses the Teamwork tools. You can help them with this task by completing all of the e-modules, attending the in-person debrief sessions, using the tools whenever possible, and encouraging others to do the same. The e-modules will introduce you to each tool separately, describe what it is and how it works, give you helpful tips on using it at work, and demonstrate their application in case scenarios. The Alliance for Innovation on Maternal Health, AIM, is a national data-driven maternal safety and quality improvement initiative based on proven implementation approaches to improving maternal safety and outcomes in the United States. AIM provides evidence-based frontline resources for birth facilities and provider and public health teams to adapt and implement a series of action steps or bundles on high-risk maternal conditions. Bundles are standardized, evidence-informed processes to reduce variation in response to maternal care. They are developed by multidisciplinary workgroups of experts in the field representing each of our alliance partners and specialty organizations. Every birth unit and outpatient triage area needs to prepare for the emergency situation of maternal hypertension, developing protocols, educating staff, and creating quick access to medications. Drills and other staff education in responding to severe maternal hypertension are critical, as well as creating the systems to assure timely and adequate treatment centering on patient needs. Early recognition of severe maternal hypertension is life-saving. Staff must note that the hemodynamics of pregnancy require action even when the pregnant woman has lived with chronic hypertension. Every unit working with pregnant and postpartum women should review correct blood pressure measurement with cuffs that are appropriate for the size and requirement of the woman. Staff should respond to early warning signs, especially unremitting headaches. Every unit engaged with pregnant or postpartum women should have a single protocol for response and treatment and escalation protocol when the protocol cannot be followed. We learn from every instance of severe hypertension and through post-event debriefs and multidisciplinary case reviews. These should take place as soon after the incident as possible. Team structure refers to the makeup or composition of your team and is an integral part of the teamwork process. Your work would likely be impossible without the assistance and collaboration of many others, each of whom serve a critical role in providing safe, effective patient care. When your team is properly structured, it can promote teamwork by including a clear leader, involving the patient, and ensuring that all team members commit to their responsibilities. The patient care team consists of anyone with whom you work independently and dynamically to provide high-quality, safe patient care. Stop for a moment and think about who you would name as your teammates. What are their names, their job titles, their responsibilities? Why is each one an essential team member? Who did you list as part of the patient care team? You probably included on your team a primary care nurse, a charge nurse, a primary care physician, an attending physician, and residents, if you work in an academic institution. You may have also listed other providers, such as midwives, technicians, surgical assistants, and physician assistants. You may have even thought to include the blood banks. But did you think about listing a patient and the family members as part of your team? Not to worry if you didn't. It's not uncommon for many providers to leave the patient and family off their list of team members. However, it is critical to acknowledge that the patient care team is not complete without the patients and their families, who should be embraced and valued as contributing partners to patient care. Although you certainly have a core team of players who help you with your immediate responsibilities, there are others who also contribute to helping ensure the organization is operating productively and patients are served at a high standard. These include the care team. This is your core team. This team is most intimately involved in direct patient care. Coordinating team, a team comprising those work area members who are responsible for managing the operational environment that supports the core team. They are responsible for day-to-day operational management, coordination functions such as triaging emergency events and prioritizing decision-making, and resource management for care teams. Ancillary. Ancillary services provide direct, task-specific, time-limited patient care. Examples include laboratory, pathology, and radiology. Support services provide indirect, service-focused tasks which help facilitate the optimal healthcare experience for patients and their families. Examples include housekeeping and sterile processing. Administrative teams establish and communicate a vision, develop policies and expectations for staff related to teamwork, support and encourage staff during implementation and culture change, hold teams accountable for team performance. Contingency teams form for emergent or specific events and are sometimes composed of members from various teams. They are responsible for immediate, direct patient care during situations requiring more resources than are available to the care team. Examples include rapid response teams and specialist consultants. It is critical to acknowledge that a patient care team is not complete without the patient. Patients and their families should be embraced and valued as contributing partners to patient care. Throughout this course, you will learn several teamwork skills, tools, and strategies that can be adapted for use by patients and their families. Thinking about how to include patients is an important part of your implementation planning that you might find challenging. Examples of effective strategies for involving patients in their care include including the patient in bedside rounds, conducting handoffs at the patient's bedside, providing patients with tools for communicating with their care team, involving patients in key committees, actively enlisting the patient's participation. A number of organizations provide information, materials, and suggested strategies related to patient engagement, including AHRQ, the DoD, Patient Safety Program, the Joint Commission, the National Patient Safety Foundation, the U.S. Department of Health and Human Services, the Institute for Healthcare Improvement, and Consumers Advancing Patient Safety. Note, the tools on this slide will be defined and explored in detail in later modules of the toolkit. We will now conclude this module with the master case scenario related to a severe hypertension case. Read through the case, which has been presented in a comic strip layout, to see the scenario that will be used and referenced throughout the entire training toolkit. At certain points in this case, you may see multiple places where clinician interactions are crucial to facilitating patient care, helping keeping them safe. These instances will be explored during other e-modules in which the teamwork tools are individually introduced. Alice Smith is a 31-year-old primipara female who is 36 weeks and 2 days pregnant when she presents to L&D triage with complaints of a headache. She has no pertinent medical history, and her pregnancy thus far has been uncomplicated except for limited prenatal care. Kim, the triage nurse, greets Miss Smith at 2:35 p.m. and checks her vitals. As she does so, they lightly joke about Miss Smith's headache and her readiness to greet her son. Kim tactfully follows up, asking Miss Smith to tell her about any other symptoms such as chest pain, belly pain, nausea, breathing difficulty, or vision spots that would be consistent with hypertension. Miss Smith tells Kim that she's experiencing some light sensitivity, which is abnormal for her as she's not prone to migraines. Kim adds the note to Miss Smith's chart. Kim also notes that Miss Smith's blood pressure is 178/112, which is significantly higher than her baseline. Kim informs Miss Smith and tells her that she would like to take her vitals again in a few minutes to see where they stand. In the meantime, Kim initiates routine admission paperwork and begins to obtain consent from Miss Smith for admission to triage. 10 minutes later, Miss Smith's blood pressure has increased to 182 over 114. Kim is concerned, so at this point she informs Miss Smith and notifies the covering obstetrician, Dr. Johnson. Kim calls Dr. Johnson, who listens intently to Kim's concerns about Miss Smith's rising blood pressures. Following Kim's briefing, Dr. Johnson requests an IV and labs and orders immediate-acting antihypertensives to treat Miss Smith's severe range blood pressures. After hanging up the phone with Dr. Johnson, Kim attempts IV access in order to obtain labs and administer IV antihypertensives. She has difficulty establishing access, so she calls out to the charge nurse, Melanie, to ask for assistance. At 3 p.m., another nurse, Beth, comes to attempt additional IV placement and draw blood. At 3:10 p.m., with Beth's help, they successfully obtain IV access and draw labs. Kim immediately rechecks Miss Smith's blood pressure, which is now 202 over 120. Kim calls Dr. Johnson again to deliver an update on Miss Smith's severe range blood pressures, explaining that the difficulty in obtaining IV access led to a delay in treatment. Dr. Johnson emphasizes immediate treatment with 5 milligrams of IV apresyline and instructs Kim to continue taking blood pressure measurements every 5 minutes. Miss Smith receives IV apresyline at 3:18 p.m. Her blood pressure drops to 198 over 110, 186 over 100, 186 over 96, and 172 over 92 over the next 20 minutes. Kim calls Dr. Johnson to deliver an update at 3:40 p.m. Still not satisfied with the improvement, Dr. Johnson orders an additional 10 milligrams of IV apresyline. In the meantime, fetal monitoring remains reassuring with a fetal heart rate in the 150s, consistent with a Category 1 tracing. However, 20 minutes following the second apresyline administration, Miss Smith's blood pressure is 158 over 84, so she is transferred to L&D given her persistent severe range blood pressures. Miss Smith's lab results return shortly after her arrival to L&D. Dr. Johnson reviews Miss Smith's vital signs and laboratory values and calls a huddle with L&D treatment team to discuss the plan for care moving forward. Miss Smith is diagnosed with severe preeclampsia and recommended to undergo an induction of labor. Her blood pressure will continue to be monitored closely, and severe range pressures will be treated when encountered. Miss Smith agrees with the plan for care, asking about whether she is still able to deliver vaginally. Dr. Johnson assures her that a vaginal delivery is still possible unless additional complications arise. Dr. Johnson and the team agree to initiate magnesium sulfate with a 6 gram per hour bolus, followed by a 2 gram per hour thereafter for seizure prophylaxis. Dr. Johnson orders for start of the magnesium sulfate. Her initial cervical exam is 2 centimeters, 50% effacement, and a station of -3 with a fetus in the vertex position. Her blood pressure is rechecked and noted to be 135 over 86. Thank you for completing the introduction module. Feel free to review it as many times as needed. It is imperative that you understand AIM's 4 R's: readiness, recognition, response, and reporting, in order to best apply the upcoming tools you will learn about in the mini-modules to their structure. These 4 R's will be discussed further as they apply to each of the teamwork and communication tools highlighted within these modules. If you have any questions at this point, direct them toward your hospital AIM team leads. They are the individuals leading the in-person trainings throughout the year, and they have been extensively trained on the implementation of the toolkit. Remember to keep applying the skills and knowledge to your real-life interactions. Try to continually think about where you can use these tools and how they may be or may have been helpful in some of your clinical situations. At this point, you can begin completing the other online modules or think about your schedule so you can plan out when you will have time to complete the remaining self-led module.